So let's start. Welcome to Bilman Ultrasound Training Institute. This is a question and answer session. Right now, what we are taking is not a course, but a question and answer session for our ongoing registered candidates. So this is just a question and answer session and not a complete course. We are conducting these sessions at regular intervals for our registered candidates. So today we got some questions from our registered candidates. Here is the display of the questions from Dr. Sunita, and then Dr. Papu, then Dr. Vijay, Dr. Tara Num, Dr. Girish, Dr. Pinky, Dr. Anita, Dr. Kef. So these are the questions which are the copy pasted questions. What I mean by copy pasted, as we copied and pasted it over here. We will discuss these questions today, and we will give opportunity to those who have not posted the question, and if they want to post any direct question to us, they have to raise the hand, not the physical hand. There is a option in more. The three dots are over there. That is more option. The raise hand. When you will be asked to pose any question directly, you can raise your digital hand, but there should be no background noise. So make sure that there is no background noise before you pose a question. So let's start the session. Please put your name first and then pose your question.
Sir, I'm Rashmi Gunni. Sir, I wanted to know how to measure the peak systolic velocity of a mature ovarian follicle. Okay,
this is already in our list today. Probably you have posted. If not you, somebody have posted this question. We will take this. How to take peak systolic velocity right now?
Yes, sir. Okay. And one more question, sir. How to measure the ovarian volume in TVS?
Okay, how to measure it ovarian volume on TVS? Let me note this. This is not in today's list. Okay, please mute yourself, Dr. Rashmi. Dr. Abhinash, if you have any question.
Myself Abhinash Mahapatra. Sir, I have given a question in the WhatsApp group, sir. My question is not listed. My question is, sir, whether primary and secondary gynecological malignancy, how will you differentiate between the two in ultrasound?
Okay, so the question is, wait, let me elaborate the question first. How to differentiate whether I'm dealing with a primary or a secondary malignancy, right?
Sir.
Okay, next.
Sir, my question is, sir, provide some slide of loco-regional gynecological spread of primary gynecological malignancies.
Okay, you want to show some slides. If you, if I have, I will surely show some slides also.
Sir.
Okay.
Sir.
Any more question from anybody? They can raise the hand. Okay. So let's start. I am having the list of questions with me. These are the list of questions. I have the printout of this these questions, and on the top I am showing you the questions. On your screen also I will show you once again the questions. So first I will entertain these questions also: how to take the ovarian volume, how to take the peak systolic velocity, how to say whether I'm dealing with primary or secondary malignancy. The list is here. Dr. Sunita is posting the question: why don't we see fetal heart rate in Doppler or power mode? Now, first of all, let me close this because I'm having a printout of these questions. I will be showing you the printouts whenever needed. Now, the point is why there is not a fetal heart rate option when I am switching from 2D to color mode, because both are different. But in some machines, even when I am putting a color, there is option of calculating the fetal heart rate. The point should not be why it is here, why it is not there. Point should be that how to take, and you have to understand the basic software of any computer. One function will be here, another will be there, but it is over there. So need not to discuss over there much why it is not there. It is not there, but it is in B mode. You have to trace in B mode, but in some machines, there is option to calculate the fetal heart rate even in power, I mean the pulse wave. Now, the next question from Dr. Pappu is that, is peak systolic velocity of ductus venosus different if we scan in first trimester and in third trimester? So the question is that whenever I am seeing to the ductus venosus, the ductus venosus, as already discussed with you, is having a high peak systolic velocity. It means that it is having a high velocity. Why we should know about this? Because we have to at times differentiate whether we are dealing with a hepatic vessel, I mean the hepatic vein, or the ductus venosus, because both are close. I may be scanning hitting accidentally the vein and taking it for the ductus venosus. There, I have to see for the velocity, because velocity is different in both. This is in color Doppler in great detail. Those who have not completed yet the color Doppler may not understand this much. But the basic important point is that why I need to see for the peak systolic velocity of the ductus venosus, because the wave itself, I mean the wave of ductus venosus and hepatic veins, they look same, not actually same. The abnormal ductus venosus looks like a normal hepatic vein. So to avoid the confusion whether I am dealing with south or north, here comes the role of the peak systolic velocity. Now the question is high velocity of ductus venosus always true for be it first trimester or third trimester? Yes. The high velocity is there in ductus venosus. I mean, the high peak systolic velocity is always and always there, be it first, be it second, or be it near term. So next point is that, next question from Dr. Pappu is that, another question, how we diagnose fetal anemia with the help of color Doppler. Now, whenever you suspect fetal anemia, you have to take the middle cerebral artery. I will not show you here slides, the whiteboard, it is already there in course. We are right now taking question and answer session only. Now, whenever you are taking the middle cerebral artery, MCA, color Doppler, I mean, the color Doppler of the MCA, you have to see again for the peak systolic velocity. Somebody posed the question right now, how to see for the peak systolic velocity. I will come to that. Now, the peak systolic velocity of the middle cerebral artery is high if I am dealing with a fetal anemia. It means that I have to see for the peak systolic velocity of the middle cerebral artery. And if middle cerebral artery is having a high peak systolic velocity, then I may be dealing with a fetal anemia. Now, you may be thinking why? Because in fetal anemia, the viscosity of the blood is low because of anemia. Now, if the blood density, the viscosity is low, that leads to the increase in the venous return and the preload. And consequently, I will be having a high cardiac output. And whenever I'm having a high cardiac output, it means that I will be having a high velocity in this middle cerebral artery. Now, how much? How much should be the peak systolic velocity? On an average, it is 30 to 40. On an average, I mean normal. In normal cases, on an average, it is 30, maybe it will be touching 40. But if it is crossed 60 or touching 60, then I am dealing with a high peak systolic velocity of middle cerebral artery, and the case can be in fetal anemia. So these were two questions from Dr. Papu. Now the next question from Dr. Vijaya is that how we can measure scar thickness by USG. We have taken in detail this fetal scar thickness maybe 15 days before during one of our interactive sessions. Okay, maybe that you were not there. I will repeat that. Now, the points here are that whenever you are putting a probe to measure the scar thickness, first, how should be the probe? Should probe be in vertical position or horizontal? I mean, should it be like this or like this? It has to be like this only. Now, the probe has to be vertical. Now, where to see? At the level of the isthmus. Next, what should be the probe used over here? Which probe? The probe, ideally, I will say, should be a transvaginal probe, not the transabdominal probe, because of the resolution. Next point, what I have to see? Have I to see the scar itself or the myometrium beneath the scar? These are very important points. I have to actually see the myometrium beneath the scar, not the scar itself. Then, whenever I am putting a probe over the isthmic region, there is the urinary bladder also. I mean the wall of the urinary bladder. The wall of the urinary bladder itself is 3 millimeters. On an average, it is 2 to 3 millimeters. If I will be calculating it with urinary bladder, it means that I am automatically adding 2 to 3 millimeters, and I think that I am having a 4 millimeter scar. Actually, that is not a 4 millimeter scar. That is the 1 millimeter scar, because 3 millimeters will be attributed to the urinary bladder. Now, to avoid these confusions, insert the probe. Because whenever you are inserting the probe, the clarity is much higher and you can see the beneath myometrium beneath the scar. Now, how much is the normal? Normal is, if it is at TVS, then if the probe used is TVS, then it is even 2 is normal. So 2, 2.5, if you got on the this TVS, then it is normal. Okay, so next question, Dr. Taranum. Dr. Taranum, please tell how to measure endometrial thickness. Now see, this is the question. Please tell how to measure the endometrial thickness. Endometrial thickness, probably you have not completed yet the gynecological ultrasound. If you had gone through this, completed rather this gynecological ultrasound, there is no chance of arising this question. That is why I am again and again, time and again, requesting to pose the question from the topic which you have completed, or at least you are undergoing. There are 3 lines. You have to include all 3 lines. That's all. Now, I will not show you how to measure, because that is a part and parcel of your gynecological ultrasound. Go through the gynecological ultrasound and this thing will be more than crystal clear. And how much? And the next part of the question is how much should be the endometrial thickness. Endometrial thickness depends on the phase. This is already in your course in detail. It will take about 2 hours to discuss about the endometrial thickness only. So what I will suggest you to complete your topic and then pose the question. You cannot pose a question before undergoing a topic. But what I will say at this particular point of time, because you have not gone through that course, I'm 101% sure that if you are having a very thick endometrium, don't take that very thick endometrium for a healthy endometrium. No, 14 and above is abnormal. If you are having a very thickened endometrium, that is also abnormal. So the 14 is the cut. Up to 14 you can accept, but if it is more than 14, then it is abnormal. So please complete the gynecological ultrasound, because this is a very basic question. This is not a question. This is a basic, very basic thing which is already taken in the course, which will be taken for you. Now, how to see for a full course of ureter from renal pelvis to UVJ, Dr. Girish. Dr. Girish, now see, I'm again taking this question because this question has been taken in previous session also. Anyhow, maybe that you are not there at that time. Whenever you see a hydronephrosis, now see, whenever you see a hydronephrosis, you have to search for the obstruction. If obstruction is from kidney, I mean, if there are multiple calculus or if calculus is in renal pelvis, then unlikely the ureter will be dilated. But if there is nothing obstructing from the kidney, then what you have to do, you have to search for the obstruction, and the obstruction can be in the ureter. Now the question is how to see for the ureter. Now you can start from kidney, then the renal pelvis. Now see, like I'm scanning right now, renal pelvis dilated, yes. Then trace it from the pelvis without leaving it. You leave it, you will not get it. This is the basic and the straightforward one tip which will show you the whole of the ureter on the screen. Now, whenever you see a dilated renal pelvis, dilated renal pelvis will be in the kidney. You, without leaving the renal pelvis, trace it. If you leave the renal pelvis, you cannot trace the ureter. And if you have lost that, go back to kidney, then come again without leaving the renal pelvis, and you will see the upper ureter. Now, from upper ureter, without leaving it, trace it. Start tracing without leaving. If you lost that, come back wherever you saw it, come back to there, and then trace it from there, and you will see a complete course of the ureter. But in mid ureter, we are having a lot of gases over there. You may not see very clear ureter in the mid part. Now, the lower ureter can be traced from the bladder itself. You see a bladder, then angle toward the right side and trace it from the bladder. So this way you can trace whole of the bladder. So the basic important point is without leaving the renal pelvis over there and without leaving the UVJ from the bladder. You lost that, you will not get it. Very easily you will not get it. You lost that, come back and try again. Now, next question from Dr. Pinky is that what is a duty factor and what will be the percentage in most ultrasound operations? Repeating the question, Dr. Pinky Agarwal is posting what is a duty factor and what will be its percentage in most ultrasound operations. These are copy pasted questions. That is why you will not understand whole of the question, but it is important to understand the question for others. The question is, what is a duty factor and what percentage of duty factor we are having in most of the ultrasound machines? First of all, let us try to understand what actually the duty factor is. There is a time when ultrasound waves are emitted by the ultrasound machine. Then there is another period when the ultrasound machine is not emitting the waves, but listening for the echoes. Try to understand. One thing is, one phase is when the ultrasound waves are being sent by the machine, and another phase is when machine is not sending the pulses but waiting and listening for the echoes to come back from the body. Now if there is in percentage I will take, if the time is 100%, most of the times the machine is sending the wave. No, most of times the machine is listening. Again repeating, if the total time is 100%, 99% of the 100% of the total time machine is listening for the echoes, and only 1% machine is sending the beam in the body. Now how much percentage machine is transmitting or sending the wave in the body is called as duty factor. Now, if I told you, if our machine, usually this is the second part of the question also, what will be the percentage in most of ultrasound machines of that duty factor? What will be the most percentage? That is 1%. Less than 1%, not even 1%. It means that less than 1% is the duty factor. In other words, the machine is sending the wave in less than 1% of total time, and more than 99% it is listening. So that way the duty factor is less than 1% in all machines. So I hope that I was able to understand this duty factor, which is not very easy, because this is a part and parcel of a very detailed thing, that is the physics, which is, I'm very sorry to state, which is very not complicated, but not interested for Indian subcontinent. I don't know why. So this is duty factor. Now, when you are increasing, when you are, I will not say increase or decrease, when you are adjusting the pulse repetitive frequency in machine, there is a button, there is a knob, PRF. When you are adjusting the PRF, you are telling on the duty factor of the machine. So yes, you can adjust the PRF, pulse repetitive frequency is that. So that way you are changing the duty factor of the machine. So your question is, the duty factor in most of machines is less than 1%. Now, from Dr. Anita, we are having another question. What is termed, when it is termed bulky uterus or bulky cervix or bulky ovaries in ultrasound? What is the cutoff? Dr. Anita, whenever the measurements are more than normal, that is bulky. Very simple. Now, what is the cut? Uterus 7.5 in length, normal. 7.5, max is 8. 8 and above, I will think why it is increased. In length, so 8 is the cut for the length, 5 for the width, and for depth it is 4. So 9, 5 and 4 are the measurements of the uterus. Now anything more than this, we call it increase or bulky. Another part of the question is that what about the ovaries? For ovaries, again, you have not even touched the gynae ultrasound, because we are discussing this in gynae ultrasound course. Anyhow, for ovaries, the cut is 3, 2 and 2. 3 is for length, 2 is for anterior posterior, and again 2 is for the right to left, that is the width. So width 2, depth 2, and the length 3 is normal for ovary. Now anything more than that, maybe that I am having a 5, 4 and 4, that is bulky. Very easy. Now another question from Dr. Kasif is that I'm reading the question as it is. My doubt for the session, my question for the session is, what is difference between acoustic impedance and attenuation? I'm repeating the question. What is difference between acoustic impedance and attenuation? Very good question. This is giving me a green signal that I am on right track by teaching you the physics. I am seeing the interest has generated in you. This physics is a backbone of this ultrasound. So I'm happy that you are now posing the questions from physics, which is a very good signal. Now, acoustic attenuation. First, let's take the attenuation. What is attenuation? Attenuation is the loss of the weakening. I will not say loss, the weakening of the beam. When beam is going in the body, it is weakening. So the weakening of beam is called attenuation. So when beam is coming from, for example, anterior to posterior, while it goes to the posterior part, it gets attenuated. So that is the attenuation of the beam. That is attenuation. Now, the acoustic impedance. Acoustic impedance is the resistance to propagation of ultrasound waves through the tissue. It means that the acoustic impedance is the resistance of the tissue itself to impede the wave. So acoustic impedance means how stiff the organ will be, so high will be the acoustic impedance of that organ. So acoustic impedance will be attributed to a tissue, to an organ, while as the attenuation means the weakening of the beam as it goes through the tissue. So these were the questions which I tried to answer. I hope that you have got your answers, whatever you have posted the questions for today's session. Now, there are some top of questions which I noted somewhere here. Yeah, volume. How to take an ovarian volume? Somebody posted how to take an ovarian volume. Now, ovarian volume, not only the ovarian volume, how to take any volume. Any volume should have 3 measurements. The 3 measurements has to be length, width, and height. Now, I cannot take all 3 in one section. Please complete your physics and machine settings, because there is a 30 minutes class for the volume only. Okay, anyhow, I am giving you a brief of the volume. Now, for these 3 measurements, I have to go to 2 sections. One is longitudinal and another is transverse. In longitudinal section, I will be getting the length of any organ or any area, whatever I want to take for the measurements, I mean the volume. The length can be taken in long section only. For depth and the width, I have to switch from longitudinal section to transverse section. So there is a B mode in your machine. In B mode, dual mode. In dual mode, there will be 2 frames on the machine. Now, put your transverse section on one side of the monitor and long section, I mean the longitudinal section, on another side. And then take these three measurements and machine will calculate the volume for you. This is very important, because if you give a wrong measurement to machine is born blind. Machine takes as if it is the actual measurement of the ovary, for example, and machine will calculate it depending on the measurement which you have gave it. So give the accurate measurements. Actual measurement is length, and that has to be in long section. Width and the depth can be taken from the transverse section. So give your accurate measurement. Then whatever machine the volume will come will be the accurate volume. That is why these PCODs are sometimes overdiagnosed or remain non-diagnosed, because sometimes you may give a wrong measurement which will tell on the volume, and volume is the eye-catching thing which will tell me think on lines of PCODs. So give accurate volume, and before accurate volume you should have two sections, one longitudinal, one transverse. Please complete your class from the machine and physics and machine settings. The volume calculation is in great detail. It is 30 to 40 minutes, the class only. So this was the volume, ovarian volume. Now somebody posted a question, how can I say whether I am dealing with the primary or secondary? Now, if there are METs, this is a common sense. If there are METs over there, if I am having a one patch anywhere in the body, only one patch, for example, in liver, I am having one patch only, it can be the primary source is here. But if I am having multiple hypoechoic areas in the liver, then I will not think on lines of a primary, but a secondary over there. Same is true for the ovary also, the uterus also. So if you see an isolated one patch over there, the things are going in favor of, the findings are going in favor of the primary. And if you see multiple areas suspected for malignancy, now you know which area can be considered for malignancy. That is a part and parcel of the course. And if you see multiple, then most probably you are dealing with the secondary. Now somebody posted a question that that is not in the list. Okay, isolated femur length, because when we have finalized the list, the candidate send a question after that. Anyhow, I noted it down over here, isolated femur length. The isolated femur length. Now, if we are having an isolated femur length, I mean a short femur length, isolated, only and only femur length is short, and that too only one. First thing, maybe you are not able to rotate your probe onto a femur. That is why the femur is not going in length. And in 80, if not 90%, this will be the case. So try to rotate your probe onto the femur, which was previously small, will now appear a normal femur. But you are sure, no, I have scanned from different planes, I try to get it, it is half of the expected femur length. So again, I'm telling you, try to get the complete length by rotating it over without leaving that small femur, so-called in inverted comma small femur. Now you have done that. Now you are sure that this is a small femur. Then previously that small femur was a risk factor, not a risk factor, a criteria for a Down syndrome. Then maybe that you are dealing with a Down syndrome. But in 80, if not 90% of cases, you scan from the different plane, maybe that you are not able to take the complete length, and don't unnecessarily, what the point is, don't unnecessarily think Downs all times. first see the scan plane. Maybe that your femur is not completely cutted. Okay, now somebody send some image. Now let us see these images, if I can get it. So I will try to go to WhatsApp and I will try to show you the image first. Yes, probably got it. Yes. So don't remember the name. I will see to the name of the doctor also. So the point here is that, let me go to the history also. The history is that, let me show you the history also. Yeah, this is the history. I am reading as it is, myself, Dr. B. Sagwan, regarding this above picture. This is 22 years, female, is having secondary amenorrhea since last 9 weeks. So 9 weeks amenorrhea. Point number 1, 9 weeks amenorrhea and having an abdominal pain. Second thing, abdominal pain, bleeding PV, mild fluid in cul-de-sac, and elevated beta HCG, and sonographically the cystic lesions on contralateral side. So please guide me whether this is the case of ectopic pregnancy or something else. Now let us go to the image. Now, time and again, I am saying you that ultrasound is a dynamic process. One image will not decide anything, but will give you an idea only. Now, first of all, this is a strong suspected case of, I will not say ectopic. Maybe this is an incomplete abortion. Why I am saying so? Because beta HCG has crossed the discriminatory zone. Now I will not repeat whole of the ectopic class over here. The beta HCG, you know, the discriminatory zone, you know, the discriminatory zone have crossed. Now I am not seeing anything in the endometrial cavity. It does not always make a diagnosis of an ectopic pregnancy. First, think on lines of maybe that this is a case of abortion. Now over here, what I am seeing over here, this endometrial cavity is having some hyperechoic dense area in it. So this can be a case of RPOCs. This can be a case of simple RPOCs. Now coming to the cystic lesion, this cystic lesion can be any cyst from ovary, or maybe that this is the corpus luteum. And fluid in cul-de-sac may be due to some infections. Don't straightway jump on to the ectopic pregnancy. Now 3000 plus is the beta HCG. If it is ectopic, it will increase but not double. But if it is abortion, it has to decrease. So the beta HCG will decide whether I am dealing with this or that. But for me, this doesn't look like an ectopic. On the top, this is a trans-abdominal probe. I have to see both sided ovaries. I have to see both sides adnexas. And if I am sure there is nothing in adnexa, then I will think more on lines of this abortion. Now, this is the area over here. This is the endometrium, which is showing me that there is some blood clot or some RPOC over there. How to differentiate whether this is RPOC or blood clot? You know it better. Put a color over there. And if it takes color, then it is RPOC. Otherwise, it's a blood clot. Now, next is this. I will read the history from here. I will read the history from another device. One more case. This is the case history sent by the doctor. One more case, a male of 20 years is having lower abdominal pain since last 6 months. Blood investigations are absolutely normal. While on scanning, I found this picture, whatever is displayed over here is not a female, but a male patient. Is it bilateral ovaries or something else? This is what the doctor is quoting. Is it persistent Mullerian duct syndrome or something else? Please guide. External genital organs are absolutely normal. Now, if external genital organs are absolutely normal, then it is not going in favor of a persistent Mullerian duct syndrome. But what this can be? This can be, now anybody comment in the comment box what that can be? Male patient having like a ovary like. What is this picture about? What this can be? What this can be? In your chat boxes, comment in the chat box. Looking like an ovary over here, comment in the chat box. In male patient, what this can be? Muscle, somebody posted muscle. No. Does it look like a muscle over here? No. These areas looking like the ovaries. Glands, Dr. Gunjan Royal. Glands. Now Dr. Pinky, seminiform tubules. These are the comment boxes over here. Now, these are the glands, seminiform glands over there, seminical vesicles, we call it. These are prominent in this patient. Maybe that he is having some infection in seminal vesicles. Maybe that there is a some prostatitis or isolated case of seminal vesicles. So in this case, you are having a prominent seminal vesicles. These are not ovaries. Okay, so these were the questions and some cases sent by our candidates, which we discussed today. Okay, Dr. Preeti is raising the hand. Dr. Renti Bala is raising the hand. Let me see why they are raising the hand if they have any question. Dr. Preeti.
Yes, sir. Good evening, sir.
Good evening. Yeah, your question.
Sir, I was studying about the multiple pregnancy yesterday from Dr. Dilip Jain book, and as well as I heard all the lectures from yours. आपके lectures बहुत अच्छे थे और बहुत informative थे. Then in the last I came to this book as you advised, Dr. Dilip Jain's book. तो उसमें सर ये anemia polycythemia sequence and this trap sequence was written that I could not get. So I thought I can ask you.
Have you completed their twin multiple pregnancy from our side?
Yes, sir. I have completed.
Okay. Now, what is your question?
Sir, I could not get anything about this twin anemia polycythemia sequence and this trap sequence.
Strap sequence. Okay, I'm very sorry. This is not a question. This is a subtopic which you want to add right now.
Yes, sir. Yes, sir.
Yeah, I will try to get a class on that, and I will add you whenever we will add that in our syllabus. You will get an intimation. If you have any question right now from whatever you have completed till now, you are most welcome. But yes, I will take your suggestion. We will try to add that in our course.
Thank you very much, sir.
Okay.
Otherwise, no question. Thank you, sir.
Dr. Renti Bala. We are sending you unmute invitation. Dr. Rashmi Gunni.
Sir, good evening, sir. I'm Dr.
Good evening.
Rashmi Gunni. Sir, my question is how to measure the peak systolic velocity of
oh, sorry, I skipped it. Somebody posted that also. Okay. Any more question you have?
No, sir.
Okay. I skipped this peak systolic velocity, how to see for the peak systolic velocity. Now see, you don't have to measure a peak systolic velocity. Let me draw it somewhere. Okay, now see over here. This is the diastole and this is the systole. Now, on this side, I am having a scale in the machine. On this side, I'm having a scale. From baseline, it will be 0, then it will be maybe 10, 20, going like this. So I will be having an eye. I will be keeping an eye over here, and I will be seeing where these peaks are. Now, in this, the peaks are about a 50. So the peak systolic velocity of this wave is 50. So the peak systolic velocity, we are not measuring, but we are seeing to this scale, and we are seeing where these peaks are reaching. If they are over here, then this is 50. So we will say that peak systolic velocity for this wave is 50. So this way we have to see for the peak systolic velocity. Anything else? Dr. P. Yadav, sending you unmute invitation. Okay, this will be the last one now. Dr. Yadav. Dr. Yadav. Dr. Yadav.
Yes, sir.
Do you have any question?
Yes.
Yeah, tell me. There is a lot of background noise from your side. You should have posted your question in the WhatsApp group, but I gave you a second option also. But in this option, what is wrong is the background noise. No, hello. Your voice is disturbing whole of the class. I'm muting you. Dr. Preeti. Dr. Preeti. Dr. Gunjan.
Sir, I want to know the difference between time gain compensation and gain button. Matlab, how to adjust that TGC. I know the TGC we have to see for some specific structure. When we want to see, we have to go for TGC. And gain is like, just want to know the difference one more time.
So the question is, what is the difference between a gain, overall gain, and TGC? Is that your question?
Yes, sir. Yes. This is my question.
Okay, done. I'm muting you. Now, as already said and discussed in the class, that the particular gain, the overall gain, I'm using word overall. Overall gain will increase or decrease the gain of the whole of the screen. of whole of the screen. Now, if I am having, now if this is the screen, if this is screen, now over here, if I will adjust with the gain, overall gain, it will increase or decrease, depends on the rotation where I will rotate it. The whole area's gain, whole monitor's gain. But if, for example, there are two areas, over here and over here, and this area, the first one is having an appropriate gain. Whenever I am putting a probe over here, this area, I don't want to make this dark, but I want to make this area dark. I mean that I don't want to increase the overall gain, but I want to increase or decrease the gain of this cystic lesion or any area, whatever is on this monitor. Now, this is in the bottomest part. This is not on the top. This is in the bottomest part. Here comes the role of TGC. Now, TGC is not a knob over there, but some sliders like this. Now, I will see which slider will work for this area, and this has to be, for example, maybe a third or a fourth over here. So by sliding this TGC, the gain of this area will decrease or increase. So if I have to decrease or increase, I mean the adjust the gain of the specific area, not the complete monitor. For that is the TGC. So I have to check which TGC will work for this. And if I want to increase or decrease, I mean adjust the gain of this area, I can do it with the top TGCs. So TGC is nothing but a specific area's gain. Okay. So
thank you, sir.
Yeah, please mute yourself. Okay, one more raise hand over there. Dr. Pinky.
Sir, I want to ask, it's a very common in ultrasonography finding bulky uterus, bulky ovary, even after the patient is asymptomatic. Is this due to probe location?
Wait. There is some issue with the mic. Please come again. Dr. Pinky.
Sir, it's a very common in ultrasonography finding bulky uterus or bulky ovary findings. But the patient is asymptomatic. Is this okay or not?
Okay, I'm muting you so that the background noise will be avoided. And the question is that it is very uncommon, common to get reports of increased sized uterus. And patient is apparently normal. Patient does not have any complaint. And it is also not very rare to have a bulky ovaries and patient is absolutely normal. This is what I told you. Whenever you take a volume, give accurate measurements. If you don't give accurate measurements, machine will give you a false volume. And you will be labeling unnecessary PCODs. You will be labeling unnecessary bulky ovaries bilateral. And you will be unnecessary investigating whole of the patient from head to toe, and you will not get any green signal for any PCODs. Point number one, maybe that doctor has not given an accurate measurement to machine. Machine is born blind. Whatever you will be giving them measurements, machine will take as if it is an accurate measurement and giving you the volume, the wrong volume, over diagnosed volume, oversized volume, I will say. That is the only cause. If there is no PCODs, then go back and see whether that doctor has taken the two measurement, two sections, the three measurements in two sections, whatever we have discussed. Number second, coming to this uterus now. For uterus, we have to give again three measurements. Now, for three measurements, I have to go to two sections and I have to put my cursors, I mean for length in longitudinal, again for in transverse, I will be taking 2. Same is true for the uterus also. That is the first possibility. If there is nothing but that has been labeled as bulky ovaries or bulky uterus. Now, second thing is that you have to add 1 centimeter. If we are dealing with a multiparous patient, you have to add 1 centimeter for each pregnancy. You have to add 1 centimeter for measurements, whatever have been said to you, 8, 5, and 4. You have to add 1 centimeter for each pregnancy. And for example, if there are 2 to 3 gravida uterus, even 10 can be normal. So this way, your patient is absolutely normal, and that has been labeled for a bulky uterus or a bulky ovaries. So I hope that I have answered all of the questions. I have at least tried. I don't know whether you got your answers or not. So I'm very sorry. My answers are always very lengthy because I want to make you understand and not to give only the answers. Answers can be in 1 line only, but I took a detailed question and answer session over here, and you can post these questions at regular intervals, and these sessions are for you only who are registered for our courses. And whenever we will announce, and most probably the next week only, we will be taking more of interactive sessions. You will get an update via our WhatsApp. You are added in our WhatsApp group, you will get an intimation of our next interactive online session. Thank you very much. God bless all of you.